The next two presentations are actually concerning post-discharge interventions of different kinds from La Belle France. And the first one is Jean-Michel Roué from the northwestern part, almost in the US, it's almost in the Atlantic, from Brest. And he is a neonatologist and also mostly involved in your area of interest has become
pain and stress assessment in newborns.
And then you will talk about
IBAIP.
This kind of intervention. So, okay. I'm very happy to have you here, Jean-Michel.
So, thank you, Björn, again for the invitation. I'm very pleased to be here, to be part of this day, and to have the opportunity to present you how we design our French IBAIP trial, which is starting soon, we hope. Thank you. As you can see, and as you probably know already, NIDCAP is now very well implemented in Europe, especially here in Sweden. And regarding France, it's now quite well implemented, and especially concerning the western part of the country, including Brest, which is a training center, and including the other centers which will participate to the trial. So that was the first step to implement NIDCAP before interesting ourselves in the post-hospital discharge early intervention programs. And now, as there is a growing evidence on the efficacy of these early intervention programs post-hospital discharge, as it was published in the last Cochrane Systematic Review in 2015, we know that there is evidence about the impact of these programs on motor and cognitive development at the age of 2 years, and with sustaining cognitive positive impact at the age of 5 years. So that's very promising, but the systematic review ended by the need of further research and the need of identifying which is the best programs and which are the components of the best program. And it appeared to us that IBAIP is probably one of the most promising program because it's based on the synaptic theory, and because it also has growing evidence and has been showed by the Amsterdam team, who published a lot of papers on the positive impact on the neurodevelopment at the age of 2, with sustaining impact at the age of 5, as Rod reported. But there's a need for external validity, meaning that we have to evaluate it in other countries with other healthcare organizations. So we have to go this way. That's in this context that we start to think of design our trial, and we have to first deal with the inherent bias associated with these early intervention programs. And we wondered if the cluster randomized control trial would be the best suited solution to design the study. And I will present you quickly how this had an impact on our trial design. So first you have to looking after the highest level of evidence to start, and fortunately there is the highest one, a systematic Cochrane review, which focused on the early developmental intervention programs provided post-hospital discharge to prevent motor and cognitive impairment in preterm infants. And as you know, there is evidence on the impact of these programs on the neurodevelopment of the preterm infants at the age of 2 and with a sustaining impact at the age of 5 years old. But there's still a need for a new randomized controlled trial, and as I said before, the systematic review ended by this sentence that additional high-quality randomized controlled trials are needed to identify effective components of successful early developmental interventions for preterm infants. So that was the first step. Is there a need for a new randomized controlled trial? Because the Amsterdam team provided a lot of evidence. Yes, obviously there is still a need for it. So we start by the usual way to design a trial using the well-known PICO-TT model to well-built the clinical question. This consists in identify precisely what is the population you will focus on, what is precisely the features of the intervention, and is there existing control intervention, and what would be the best suited outcome to assess. And this model ended by defining the best type of the study design to respond to this answer. And when you go this way, step by step, that's the beginning of the problems, because you have to deal with all the bias. And most of times, a classical randomized control trial can deal with most of this bias. But it appeared to us that probably the contamination bias would be, in this case, in the context of our healthcare organization, plus the features of the intervention of IBAIP, that contamination bias will remain in a classical randomized control trial. Indeed, if you look at the selection bias, for example, if you select patient from trained NIDCAP center or non-trained NIDCAP centers, you will have a selection bias. You can deal with that with only selecting NIDCAP centers, so that's not obviously a problem. That's the same for control group bias. You could have, before the trial, pre-existing post-hospital intervention like the sensory motor intervention, which is quite spread out in France. But you can deal with it if you integrate it in your analysis as a confounding bias. But there is a remaining bias, which is the contamination bias, in the specific case of early interventional program, which is this contamination bias, because the trained caregivers, the caregivers who will be trained to the IBAP, will have an influence on their practice with the babies in the intervention group if they care of the baby in the control group. And if you take 2 caregivers, usually in France is physiotherapists, even if you have a trained physiotherapist to IBAP will only take care of the patient in the intervention group, the physiotherapist taking care of the patient of the control group, they will usually talk together and influence each other in their practice. So that's a big deal, and it appeared to us that maybe in our situation, in our context, the cluster randomized control trial would be maybe the best suited answer to design our trial. When you interest yourself in these topics, you will see if you go on the PubMed that there is excuse me, an increasing interest in these topics over the last 20 years because it gives answer to some designs. And the global concept is that patients are not allocated to a treatment individually, but as a group. That's a good solution, but it has also implication in the trial design, meaning that in a same cluster, the patient would be more similar to each other than 2 patients in 2 different clusters. That means that you will have correlated data in the same cluster, and you have to inflate your sample size. So you will need more patients to have the same statistical power. So that's the first problem. You have to deal with it. And the other problem is that this correlation will need complex, specific statistical analysis like mixed models. So you will need to have a very experienced methodologist statistician to design such a trial. Fortunately, we have in our pediatric research network Professor Bruno Giraudot, who is a reference in this topic and has reported a lot of evidence on this topic of cluster randomized control trial, and is already involved in the trial and will support us to implement this specific design. The other implication is an ethical issue, because it's unusual to randomize the clusters before recruiting the patient. And in this case, the units will be randomized and then you will recruit the patient. So the patient could know obviously in what group they will be recruited for. So there is a debate and ethical issues of how we have to inform the patient. Do we have to tell them in what group they will be recruited or not? It's a big issue that we will have to deal with it. If you choose cluster randomized trial, you have to get a benefit from it because there's disadvantages. For recall, double-blind randomized control trial is the gold standard. So you have to get advantages from it. In our case, the biggest advantages was the fact of controlling contamination across individuals, but in some cases it can be the studying intervention that cannot be directed towards selected individuals. The main disadvantages I introduced to you a little bit is that there is a dependence between individuals in a cluster, and you will need more patients for the same statistical power and a greater complexity in design. So you need experienced methodologists to go to it. So in practice, saying that, how we did to set up this trial, as it is recommended for a cluster randomized control trial, you need at least 6 or 8 clusters. And so we have, at the opportunity, we already work with 6 units together in the western part of France. It's the Western University Hospitals Pediatric Research Networks. So it represents 6 level 3 university in ICU with around 20,000 births a year. So they are all NIDCAP centers, certified or in training. And we added two other university hospitals which have quite the same level size than breast hospitals. So 8 level 3 university, all NIDCAP centers. Our main objective will be to assess the impact of the IBAIP trial on the neuromotor developmental outcome at the age of 2 years old. As I said, we will use a multi-center cluster randomized control trial, and the population will be the preterm infants between 25 weekers until less than 33 weekers. There will be exclusion and inclusion criteria, of course, and they will need to have a normal neurological examination according to amyloidism at the discharge. Our primary outcome will be the Revised Brunelleschi Developmental Scale at 2 years of age, because our neuropsychologists are now often trained to the Bayley, so we have to use this scale. As the secondary outcomes, we will assess the impact on parents' health using the parenting stress index, We'll also assess the ages and stages questionnaires, and we will take into account in the analysis the confounding factors as gestational age, BPD, patent ductus arteriosus, and socio-educative environment. And as all NIDCAP, all the units are NIDCAP centers, we are also taking into account the number of NIDCAP observation during the hospital stay, which could be a bias in the analysis. One of the major impacts of using a cluster randomized control trial on the design is the inflation of the sample size, as I say. So in a classical randomized control trial, trying to show an increase of the developmental quotient of 5 points with a statistical power of 90%, we will need 225 newborn, meaning 112 approximately in each group. And by using cluster randomized control trial, we will go up to 340 patients, accounting so for the intra-class correlation and integrating a 10% loss of follow-up and withdrawals. So in practice, that means that we'll need 170 patients in the IBAIP group and 170 patients in the control group with approximately 42 patients per unit. Where are we now? We are currently trying to translate all the documents of the IBAIP in French. We hope that at the end of this month, we'll be able to, with the help of the methodologists, we'll be able to randomize the centers. And so in around May, June, we'll be able to recruit the trainees. And we are planning with Rod the first IBAP workshop at the end of this year. And as Rod said, the training needs approximately a year. So the inclusion will only start at the early beginning of 2018. So it takes time, but we will deal with it. So I thank you for your attention.
Very good. Thank you very, very much for this excellent presentation on methodologies that are so important. And we do have, since we cannot blind our intervention, this is probably the best way to do it. I mean, but it takes more money and more engagement. And we are impressed, Jacques, where are you? That you have so many 8 NICUs, level 3 NICUs. They are not NIDCAP centers, but they have NIDCAP professionals in all these NICUs in your region or close to your region. It's a great achievement. I'm impressed. So the floor is open for questions or comments. And sådär.
Thank you very much. I wonder how many trainees do you anticipate or plan for?
2 trainees per center, which will be randomized in the intervention group, and we will add 2 more trainees to coordinate the training when Rod will be back to the US.
So you think the need would be 4 interventionists per
unit 2.
Per unit 2. And the inclusion period, you said 42 approximately 42
patients
per center.
Yes.
So that will be. Are they very different in size? How long do you think the inclusion period will take?
We plan 1 year, and normally all the units are able to do more inclusion than 42. It represents half of their recruitment.
Okay.
Just an additional question. Is there any way that you can do blinded assessment? I know that's more difficult when you have cluster randomization. I mean, it's no problem if you have randomized on an individual basis, but with cluster randomization, do you have any idea on how to possibly blind the assessment?
The assessment at 2 years.
Or won't that be possible?
We didn't exactly plan this, but it could be discussed.
Could the assessments be done by watching video tapes, video recordings? Is that possible?
I think so.
Because then that would open up for blindness, of course. If you could videotape and then send the tape to someone to assess.
Yes, that's a good idea.
But it's a very important question.